Welcome, everybody. Hi, Susan. Hi, Eliana. Nice to see you, Troy. Welcome.
Amy, are you seeing my screen?
No, I'm not seeing your screen.
Okay.
Is it working okay?
My Zoom just kind of went away, but clearly you're still on.
We're still on. It is really hard to see your, like you can't see your slides while you're presenting for the most part. So if you want, Sammy or I to do your slides, I always do my slides and just hope for the best when I can't see people and stuff. And we'll be on like a chat duty if people are, kind of trying to comment or have questions during the presentation. However and we can handle that however you want. If you want to have people jump in, or if you want to just hold questions. Sorry, everybody, we're just getting our tech set up so that we have the slideshow ready to go.
Okay. I think I see now.
You have to have the slides open somewhere on your, and then when you get that green share arrow, it should give you a couple different choices of what you want to share.
Yeah, so let me try this again.
Okay. Yep, that worked.
All right.
Beautiful. You can do the only thing, like, yeah, switching to slideshow view. There you go. Will not have notes on it.
All right.
Oh, that's perfect. It looks amazing.
All right. Awesome.
Great. I'm really so grateful and thrilled to introduce Dr. Cherise Hamblin. She is new to the Worcester area. And I got a chance to meet her in person, and that was, of course, amazing at the NAACP cookout. And hear a little bit about your work and what brings you here. And we haven't always
For me, Amy cut out.
I
Is
can
it? Oh,
sorry. I can hear, I didn't hear you. So I'm hoping that it'll be fine. Maybe, I'm sorry if you didn't hear me. Everyone, people are seeing and hearing okay. If you want to just,
Amy, I think you were cutting in and out. We can hear you now, but earlier there was a break.
people said that, yeah, you froze for a second. I'm sorry, that's terrible. I don't know, the Zoom world. Hopefully we won't have any problems. Everything will go beautifully. And maybe I should just zip it and hand it right on over to you, Dr. Hamblin, and you can give more about your background and growing up in the Bronx and what brought you to this work.
you have a great memory. Yeah, I'm happy to take it on. So, hi everyone. Thank you so much for having me, Amy. I really appreciate the invitation. I did kind of scroll through who was here, and I see some of the doula program team here. So, I'm not going to sweat or anything because talking is my jam, and I don't have to see how many people are in here because I can't really see everything. I'm going to go through the UMass Memorial Doula program and talk about this is what we call the roadshow, but then I will pivot and change over to a second presentation that is more kind of foundational about how I like to think about this work and what I think, things that I think will be pertinent to this audience. One of my kind of pet peeves when we're talking about trauma informed is when that trauma informed lens, does not include racism. I'm like, well, then we're not talking about trauma. Like, I don't understand. I don't understand that. And so there's, I'm a little bit of a curmudgeon. I'm older than I look and all of those things, but I'm going to jump right into my presentation. So I'm going to hide myself so I don't see this and I can just kind of get focused. So the UMass Memorial Doula Program, the idea of the program is really to improve the outcomes and the experiences of Black birthing people at UMass Memorial. As Amy said, I'm from the Bronx. I was born and raised there. I moved from the Bronx to Pennsylvania for college. I went to Franklin and Marshall College. And at that time, I knew that I wanted to be an OBGYN. I knew that I wanted to study abroad. I knew a lot of things. Like, I kind of had this vision of my future. And I am so grateful and thankful that the lights were green and that people were put in my path to help me realize the visions that I had for myself and that my family had for me, from that age of 14 when I first said, okay, I like biology. And my dad said, well, you can be a doctor. That path then moved from Pennsylvania to Chicago for medical school at Northwestern, and then Phoenix for residency. In my residency in Phoenix, that is where I met Krista Johnson-Okbaku, who is the executive director of the Collaborative in Health Equity. And so when I was in my residency, she was in her first attending role out of fellowship, and she was starting the Refugee Women's Clinic at Maricopa Medical Center, which then went on for the next about 15 years. And after residency, I moved back to Lancaster, Pennsylvania, which is most known for the Amish, and sometimes referred to as the home birth capital of the country. But it has so much. And Lancaster is actually very similar to Worcester, where you have a city that is very diverse. We're filled with immigrant communities based on world conflicts, based on migration patterns, et cetera. And the county is much larger and much more white, and much more homogenous. And so there's an interesting juxtaposition. So I've been in Lancaster, Pennsylvania for the last 13 years, and 5 years ago launched a community doula program with a dear friend and colleague, Dr. Cherie Livingston. And so that work in those 5 years and my whole life has led to the thinking about how can doula support really transform the maternal health landscape, and the focus of the UMass program being built around improving the supports and the experiences of Black birthing people. If we advantage Black people, everybody will do better. If we understand how racism works, particularly how anti-Black racism works, there is a hierarchy of things. And so if you start at the bottom of those people who are most affected and have the worst outcomes, a rising tide lifts all boats. So I love this diagram that Chantel shared. Chantel Collins is the program coordinator for the doula program. I think she's here. The birthing person and the baby are in the center of this. Many times in medicine, we put ourselves in the center. We as physicians, as care providers. Nursing does a better job at getting themselves on the periphery, but sometimes these patients are not our friends. They're not our families. Ideally, you develop a really great and robust relationship with your patient where that may be where you're considered, but like, it's not a given. And so really valuing that person and their family and their chosen support as the central components, and we can all assemble around to wrap these birthing people in cocoon of safety and support. And so our program goal is decreasing severe maternal morbidity. So I think you'd have to be hiding to not know that we have a maternal mortality crisis in the United States, where for a country of our size and resources, we are an outlier with how many women and birthing people die in and around childbirth. But it's not just about death. It is also about having a near miss or a severe maternal morbidity event. And those are over 20 ICD-9 codes or ICD-10 codes that hospitals across the country are tracking. We know that doula support is beneficial. I'll get more into that. The program really is seeking to improve and increase the trust with the Maternity Center and UMass Memorial Health with the Black community. And workforce diversification and development. If you do not have a diverse workforce, it is because of racism. And, you know, if you want to argue with somebody else, because I cannot be convinced. So the program focus again is on Black birthing people. When we disaggregate the data and look at severe maternal morbidity in Massachusetts by race and ethnicity, you can see these different lines. The highest line or the outlier is the Black non-Hispanic. I was going to try to do something fancy, but I'm not going to do that and mess up my whole presentation. If we're looking across the country, this map is from America's Health Rankings. You can go onto their website and they have interactive maps where you can see severe maternal morbidity, and they use other things as well. So this may be a good resource for folks to create a map that you can see of the health topic that you're looking for. When we look at the states and states that are reporting severe maternal morbidity, so this is life-threatening events, there's about 20 codes, diagnosis codes, and that's the rate per 10,000 delivery hospitalizations. Look at where we are as Massachusetts, and who would have thunk that the Commonwealth of Massachusetts, this great state, would be so far down in the rankings, and down is bad. That's a high number, that's too many near misses. New York, I think New York is well known for having bad birth outcomes. But you wouldn't have thought that Massachusetts, in this enlightened state with lots of wonderful progressive people and all of these things, that we would be doing so poorly. When it comes down to disaggregating the data, Massachusetts surpasses New York in badness. I think that my little thing is blocking a part of this. I don't know if you can see. Can you all see the top of this?
Yeah, we can see it well,
Okay.
how bad we are.
Okay. Yes. And so this is disaggregating data saying for Black non-Hispanic birthing people, what are your outcomes? This was a shock to our CEO. You know, he was like, wait, what? We're worse than Mississippi. Now, why are we worse than Mississippi? I'm wondering, is it, you know, is the data complete? There's only 33 states listed here, so not all states report their data disaggregated by race. But still, 33 is nowhere where we want to be. So what would happen if we give, you know, patients who have the worst outcomes the best that we have to offer? That's a thought that lingers in my mind. And as, you know, the world woke up to racism being an everyday active issue, you know, in 2020 with the murder of George Floyd, something that I was like, okay, welcome to the party. It was very interesting to me to hear things that I know from my own personal life and from my community context talked about in medical spaces. And I had a glimmer of hope at that time, like, wow, you know, we're really going to talk about this. Okay, I'm here for it. So we know now, study after study after study shows how racism shows up in medicine. So if we look at the map that's in the top left, you have historic redlining, issue of the 1960s and 70s, where banks laid out on a map and said, oh, no, these redlined areas are high risk and we should not write home loans to them. So you think about, you know, you had, I want to say World War II, people coming home, and there was a great effort to promote home ownership. Okay, we can, you know, advantage these veterans. When you think about VA benefits, all of these different things, Black veterans were not included in those benefits. And the biggest driver of wealth in this country is home ownership. And so if you think about this, it makes a lot of sense that your zip code and what happens in your community, when we think about the social drivers of health, you can remove the red lines, remove the practice of redlining, but there's been no repair of that harm. So when we think about maps and we think about food deserts, is it really a food desert or is it food apartheid? If a less than 5 mile distance shows you 10 years difference in your life expectancy. And we understand social drivers of health. So then what are we doing to repair those things? What are we doing now, again, to advantage those who are harmed by racism? How does racism work? Racism is a social and political and economic, issue, and race is a social construct, right? It's not genetic based. So if you are perceived as Black, you will experience anti-Black racism, whether or not you recognize it. So in the context of thinking about all of this and saying, well, in Pennsylvania 5 years ago, we started a program, when the department had reached out to me when I was living in Pennsylvania and said, well, we're going to have a doula program here. We'd love to, maybe just talk with you, get some ideas, let's compare notes. And I said, fine, sure. So we start talking and, at the root of what they wanted to do was help Black birthing people improve the outcomes of Black birthing people. I think that as systems really took a look inward, they were embarrassed to see that when they disaggregate their own data, it's universal. Racism is pervasive. It's in the water, it's in the air. It is everywhere. If you think that it's not in your system, in your area, in your work, then you're probably on the wrong call, right? And so it's all of our job together to kind of see where is it showing up and how can we root it out? How can we work against it? If we want to work against racism, we have to advantage Black people. So understanding the landscape in Worcester, I set out to make some Black doula friends. I just wanted to understand what was going on here. Some of you may have met Anaya Sanders. She started working for UMass Memorial as the doula program coordinator in October of last year. And she was very instrumental in understanding the landscape.
It's all about how cool kids are doing.
Lots of work around the Commonwealth to understand the doula landscape as Mass Health was preparing to start covering doula services. And so we got some knowledge of people who were in this area doing this work, some of whom you see on the screen here. And there were several grants that were going around. I think the REACH grant, I don't know if anybody was trained by the REACH grant, put it in the chat. At the same time, we were, I was recruited and started to flesh out the program and look at it and say, okay, is this program, like, are we really gonna do this? A program focused on Black people. Like, I hadn't seen it, I've wanted it, and that's what we're doing. So there's a big commitment on UMass Memorial and on UMass Chan around, combating racism in the strategic plan. And so on paper, out loud, there's commitment, and I'm seeing it as well in the systems way. Some of you should be familiar with Dr. Gibbs. Brian Gibbs is the Chief Diversity Officer for the health system. And so getting into what's a doula. A doula is a non-clinical professional, support person who comes alongside expectant person and their family, provide emotional, physical, educational, and informational support. The doula, you can even think of a doula as, I say to patients, the person in your family or in your friend group who has either the most kids or everybody knows, hey, if you're having a baby, this is the person that you want to be around because they have a calming influence. They know the questions to ask. I think, some people say like, oh, doulas aren't made, they just exist. And I wasn't always a believer in doulas. Again, from the standpoint of a medical system, you have a lot of arrogance where doctors, we have the tendency to put ourselves in the center and be like, it's me and my patient. It's like, listen, this woman doesn't know me. So we just have to have more humility, and people who are working as doulas often are doing so not in a formal capacity. Sometimes it's like, oh, this is the thing that I do, but I wouldn't have called it that. There are several benefits of doula support, and this is evidence-based. Decreased C-section rate is associated with doula support. Improved satisfaction with the experience. And many states across the country have opted to cover doula support on their version of Medicaid, and time after time, each state references it as a way to drive health equity. Now, I have not seen any state do it based on race. I mean, and I can understand that, like, the landscape is changing, there's a lot of uncertainty. And I think sometimes we get into these conversations that are like, well, we can't legally do this, or we can't legally do that. Well, racism is not legal either, and discrimination is not legal. So let's kind of be brave and really be specific when we're talking about things. I think that's one of the things about, as I mentioned, trauma informed. A lot of times we dance around racism as a trauma that is experienced on a day-to-day basis. And if we're talking about trauma and we're not talking about racism, we are not doing the work justice. So I had mentioned about the program, and so patients can, this is a program that is in existence for people delivering at UMass Memorial Health. There is a program website, program brochures and flyers, the inclusion criteria, self-identified as Black, delivering at UMass Memorial, and somewhere between 16 and 36 weeks. We do not want to, it's not dial a doula, it's not a last minute, oh, no one's here, have somebody come in on call. The relationship, if you go back to thinking about that first image, the patient and baby is at the center, and the support persons are around. It takes time to build relationship with patients and families, and doulas do that beautifully, and it requires, time to build those relationships. And our team, which consists of a program coordinator and 2 doula program navigators, Chantel Collins, Janice Grunder, and Renika Anglade. I think I saw a couple, and maybe you can like wave or something, or put a thumbs up in your chat box, just to identify yourselves. And they come alongside, so you get, as Chantel likes to say, a doula and a half, or your patients or your clients get this. And doesn't matter who your insurance is, doesn't matter who your doctor is, doesn't matter, what language you speak. And so the program materials are available in English, Spanish, Haitian Creole, and Brazilian Portuguese. And then there's the overarching, Mass Health is covering doula support. So there's a Mass Health provider directory. It's overlaid on top of this or under it, however you want to look at it. But there's a lot of people in our state who can get doula support. And so I think it's important to understand how can you engage that support for your clients, for your patients, for people that you serve and in your communities, and what do you expect from it? We've had these numbers are not up to date, but you get the picture that the website really launched in May, and there's lots of folks who are supporting families in our community. This is what the team looked like a couple months ago, and this is what our brochure looks like. And so if you are someone who wants some of these physical materials, if you could put your name and email in the chat, we can get you all of these things. Our website is on the Maternity Center website, and it's a simple form, takes less than a minute to fill out, asking the patient just their contact information, the way they want to be contacted, and the form is available in English, Spanish, Creole, Portuguese, and Twi. There's also an internal like a referral for providers if you're on the Epic system. But this is contact information. I'm gonna stop sharing and just see what the chat says, and then I want to bring up the other presentation that I had teased and talked to you about a little bit, because I want us to go more in depth. But before I do, are there any initial questions?
From what I saw in the chat, people were just really appreciative that you were calling this racism, recognizing that racism is what's going on here, not trying to make it something other than it is, and addressing it directly. Worcester addresses childhood trauma. We consider racism to be trauma. Absolutely. So we are on the same page with you as far as let's call this what it is. That's the only way we're actually going to make any positive gains, is if we're honest about the problems and the issues.
Exactly, exactly. So I'm going to pivot to this presentation so I gave this as grand rounds, and I can actually put a link to the YouTube video recording of it, but like I feel free to interrupt me and like ask a question. We kind of laid the groundwork of the program, right? I presented this with Nikia Lawson, who's a doula trainer that I've been working with for the last 5 years through Patients Are Waiting, which is a nonprofit that I founded with 2 other OBGYNs, wonderful people in Lancaster, Pennsylvania. And in this grand rounds, which was to the OBGYN department, talking about doulas and what they do. So talking to a bunch of OBs who are used to putting themselves in the center and saying, hey, step back. Or I'll make a movie reference, which any talk I give would not be complete without a movie reference. Jump back, boy. Does anybody know what that's from? And this is a 90s movie. If you know it, say it out. And I don't know why I'm like this. It was actually it's from How Stella Got Her Groove Back. The guy says this to Taye Diggs. Anyway, what are the benefits of doula support? We kind of touched on, and how providers can engage doula support for their patients. I won't belabor these issues, but we have beautiful pictures and beautiful people. And so if your work is around breastfeeding rates, if your work is around, substance use disorder, if your work is around people with intimate partner violence, like this is a resource that you should engage for your clients and for the people you serve. I'm going to skip the video.
For me, we're not seeing your screen if you have that.
No? Okay,
No.
hold on. Okay. Exit. So I have to get back to. Okay. Thank you for saying something. Are you seeing it now?
Sure are. Good
Okay.
job.
All right. Here we go. So this was the beautiful image that I was talking through. So again, if your work is in, I think in this setting, if we can think about how can your work be helped or supported by doulas? Okay. I am going to skip the video.
Need to be a doula.
And so just very recently, we all, Chantel and myself and Sabrina, who was just on that video that you didn't get to see, exhausted ourselves with, there are 14 local women who underwent doula training through the Diversifying Doulas Initiative program. That's 8 weeks online meeting from 6 to 8 on Wednesdays, where various topics through childbirth education, birthing while Black, lots of topics were gone over in that virtual course. Then last weekend, they were at Memorial doing a 2-day hands-on training. And now they will start to receive and support clients, patients in our community. And then over the next several months, they will go through certified breastfeeding specialist training and mental health first aid training. And they'll continue to be a part of the Patients Are Waiting ecosystem. And so that network of people, while the organization is based in Pennsylvania, because the mission of the organization is increase diversity in medicine as a means of eliminating health disparities. When you're trying to build doctors, like I mentioned my trajectory, I went from the Bronx to Pennsylvania to Chicago to Phoenix. I've been all over the country. And becoming a doctor, it takes about a decade. And so if this person is coming a PhD in biomedical science, if someone is becoming a nutritionist, someone is becoming a dentist, someone is becoming a doula, like there may be varying lengths. And as an organization, we really kind of provide that longitudinal support. And for some people, being a doula is not their final destination, but it is a phase or a time or a step in their journey. All right, so you've seen this already, and this as well. When I'm talking to physicians, I really try to hone in on this point. It is not an us versus them. We're all working for the patient from the physician's standpoint, or for the client from the doula standpoint. And we're all living in community. So when we think about like, what are our goals? The goals are the goals of the collective. We want to have safe birth. We want to have good outcomes. We don't want to be at the bottom of the list as a Commonwealth. No one wants their hospital or their system to be an outlier. You know, in general, we think about C-sections as a bad thing, just as an indicator. If your C-section rate is high, you have higher complication rate, higher, you know, so decreasing C-section is good, increasing breastfeeding is good, right? And so if we're all working toward these same goals, it's how can we work collaboratively? How can we work in coordination to achieve the goals? Not thinking me in the center. And that can be hard. Sometimes I find that there's a lot of discussion around the reimbursement of doulas. A doula getting paid for their work doesn't take anything away from me. It's a really limited mindset that kind of argues that. It's like, what? I don't get paid enough for this. If you don't like it, do something else. I mean, in general, physicians, we're in a position of privilege. And so one of the things that I do is try to shut down some of those discussions or comments, and because ultimately it's not productive, right? And then again, the collaboration is so important. And I think that we can talk about building trust all we want, but if we're saying, oh, we're trying to build trust, how do you build trust? By being trustworthy. So you can't tell me to trust you and then you do foolishness over here, right? I'm an OBGYN, so I think about everything in terms of relationships. If I'm with a cheater and they're like, oh, baby, trust me. Well, don't cheat. And then maybe I would trust you. But if you're going to continue to do it, why would I believe anything coming out of your mouth? And I think that's a very simple way to break it down for like what is the experience of Black people in healthcare? Because it's your experience in society. So whether it is in the clinical interaction or with the security guard when you are, you know, trying to drop off, you know, or receive flyers, and this is a real example for me, you know, if your experience is one where you are feeling singled out, discriminated against, not listened to, or not heard, you're not going to be operating with, you know, high trust levels. This is where I lay out, you know, basically, you know, the US being an outlier. We're all the way at the right as far as, you know, maternal deaths per 100,000 live births. And when we disaggregate by race, ta-da, 2 times higher, you know, for Black birthing people. You've seen these slides already in the other presentation. And then this, it was like 2 o'clock in the morning as I was finalizing these slides. And you see the redlining map on the right-hand side, and you see the social drivers of health, and you see these outcomes. But when we look at these health outcomes, we have to understand these are fruit of the rotten tree. Like, you know, anybody know the Deborah Cox reference here? Can someone come off of mute? Nobody's gonna be brave.
What were you asking for, sis?
Oh,
Because
this
I'm over
Deborah
here
Cox.
clapping like a lot.
Yes,
So
the Deborah Cox reference right here. It's like, how did we get here?
the fruit of the rotten tree.
Yes.
So from the root to the fruit, if we don't eradicate it at the bottom, then it's going to continuously grow and permeate throughout.
Exactly. So when we're looking at, oh, diabetes and the amputation rates among Black people, this, that, and third, well, your racism is showing. Like, right, let's look at that. That affects the roots of all of these things. Your racism, xenophobia, distribution of resources. Look to the right. Deborah Cox had a song that had the 90s in a chokehold. How did you get here? Right? Okay. So another thing that I found not entertaining, but like so sad that I have to smile so that I do not cry. A couple of years ago, I came across this And my mind was really blown. In gynecology, you learn about Sims, the father of gynecology, and he did these experiments on Black women who had no anesthesia and all of these bad things. And I thought that was bad. I said, oh my goodness, I used this Sims retractor and I don't want to call it that anymore. And then I learned this. Slavery was a driving force for the formalization of medicine. Let me say that again. Slavery was a driving force for the formalization of medicine. So let's just think, and none of us were there, okay? And I'm not blaming anyone, right? In the 1600s, right? 1600 or 1619 to 1808, transatlantic slave trade. When we think about the practice of medicine, right? It was called that for a reason. Do you think that medical schools existed when Adam and Eve? No, right? So there was a teaching, a passing down of knowledge, okay? There's someone in your community who's a healer, somebody who's kind of good at doing something. Maybe they know what herbs to mix together to settle your tummy, all that stuff. In the transatlantic slave trade, you're going to have someone saying, I got a boat. This boat can make it that 21 to 90-day journey. And how many people can this boat fit? All right. So I'm going to find someone who's going to commission or pay for my fees so I can get across the ocean. I've got a contact on the coast who's going to help me steal the people. We're going to get them on the ship and we're going to ride back. Now, if I ride back 90 days, 21 if I'm moving fast, and a lot of people die, I'm coming back empty-handed. So who do you think was on the boat to make sure that either people stayed alive or you figured out who was dying and who was contagious and throw them off? Is anybody with me? I'm gonna need an amen, something. Okay. So
Amen and yes.
thank you. So, health was a commodity during transatlantic slave trade. European doctors were hired for care on these journeys. And if you were a slave doctor who predicted well, then you got more jobs. The original pay for performance. Oh boy. All right. So 1850s now, transatlantic slave trade is over. Now people are being bred in the United States, here, and in the Caribbean. Said no, England said no more, or whomever, or whether it was a conscience. But it was, slavery continued, and the conditions were horrendous. Poor nutrition, working from sun up to sundown, dirt bottomed, places where people were living. And when you think about this idea again of Sims on these women, these were not women, these were girls. So if now the age of menarche is between like 9 and 12, and this time it was a little bit older, maybe 13, 14. By the time someone bled, okay, and now they could become pregnant, they were bred. They were bred to have more children so that they could be more of that workforce. And so if you have people who are being forced to bear children at a very young age, they have poor nutrition, poor living conditions. What do you think the delivery conditions are? Pristine? No. And so if someone had obstetric trauma where baby was big, or they a protracted labor, or they had a tear from their vagina through their anus, do you think that healing happened very well? No, but that person now was worthless because they cannot go back out in the field working and picking cotton if they're incontinent, unsanitary, smelly, all of those things. They now become a social pariah in their own community, and they are worthless to the slave owner. And here comes James Marion Sims, who was a physician, again, the practice of a physician, right? Very interested in making a name for himself, and he practiced everything from dentistry to pediatrics to surgery. So this medical schools didn't exist. They weren't a thing. You were learning from someone and you were just out here trying stuff. And so he purchased some of these enslaved girls who were worthless now to their masters, but now they were still a mouth to feed, and said, I will try to fix them and see what happens. And we can all see this picture, and many medical schools or textbooks will show this, which is depicting Sims about to perform one of these surgeries on Anarcha, Betsy, and Lucy are the three enslaved girls who it's documented. And he wrote these in the medical journals. He wrote them in his, in his logs, and published this. It's not hidden history. It's out there in plain sight, being held, the girl screaming, and pain medication existed. Like inhalation, opioids, like they got that after. So he then had them kind of strung out in this back shed in his and on his land in Alabama after the procedures were done. But again, because people were looked at as less than human, they were not given the benefit of anesthesia. So when we think about the timeline of where we've been and where we are, it becomes less surprising or confusing of where we are today with the stats that we talked about. I love this timeline just because, again, when we put it on slavery times, the birth of gynecology, even here on the bottom, we talk about Samuel Cartwright, diseases, Black diseases of Black people, drapetomania, like wanting to run away. Why would an enslaved person want to run away? And so even like the beginnings of psychology and psychiatry have racist underpinnings. Today on Marion Sims' land is the Mothers of Gynecology Museum, and basically an artist from Alabama bought his land and is educating people about this history and about this work. There's a book called Say Anarcha that is really powerful, that goes into some of this history as well. Medical Apartheid touches on it by Harriet Washington. So what's the opportunity here? That was like super depressing, right? But we have to know where we've been to really kind of like be honest about where we're going and why we are here. Again, Deborah Cox, how did you get here? Okay. Percentage of births paid for by Medicaid across the country. So Massachusetts is like number 10 or 11 of states that are covering doulas through Medicaid. And California has been doing it for a long time. New York has been doing it. It's not working there, is it? Right? We looked at the stats about New York. So we have an opportunity here. As of December 8th of last year, Massachusetts Medicaid, Mass Health covers doula support. So we think about all of the benefits. We think about people who have Medicaid across the Commonwealth, or this is, I'm sorry, I don't recall if this is the Commonwealth or if this is the country. But even when we're talking about Medicaid, I think a lot of times people like to paint a picture like, oh yeah, all these Black people, and they have Medicaid. Look at who's the majority of people on Medicaid. But anywho, we will still, if we focus on the people being affected the most, then we will improve the health care outcomes for everyone. I bring this point out just because whether it's on good or bad, right? Whether you're in the narrative of like, oh, Black people are always poor. If we treat poverty, then we'll be treating Black people. Or if we have on the other side of like, well, why is this only for Black people? First of all, doulas being covered by Medicaid can help anybody who has Medicaid. But if we're talking about addressing a health disparity, and in health disparities, the racial is silent. Racial health disparities, look it up, 1980, Institute of Medicine, unequal treatment. I said what I said. So if we're talking about addressing racial health disparities, we cannot use a health disparities narrative to garner support and get something done, and then use an all lives matter approach to, solutions, in my opinion. So I did mention that December 8th of last year, this is coming up on a year that doula support has been covered by Mass Health in the Commonwealth. Doulas are reimbursed or paid up to $1,700 per birth. And there's some nuance to how that billing goes. But there's 70,000 births per year in Massachusetts, and 40% of them are covered by Medicaid. Last I checked, which this is about 2 weeks old, there were 155 doulas in the provider directory. We literally just had a session for the 14 newly trained doulas through the UMass program to help them get through their paperwork so that they can be added to this Mass Health provider directory. There's lots of states with doula programs and some kind of coverage. And this is kind of going into like, you know, the UMass doula program is not your average hospital-based doula program. Again, and it's based on what are our goals? What are we trying to do? Who is running it? Who is the team? And who does the doula work for? The doula works for the client and their family, right? Because the patient is at the center. This goal, you've seen this already. So we ended on, you know, how do you engage doula support for patients and that information. Kind of I smushed the two presentations together. So I will stop sharing my screen, and I'm hoping that we can just have, you know, some discussion, some conversation. Thank you for your
Kanisha,
time and attention.
I'm so glad my friend Kanisha's here because she had a lot of reactions. She was waiting to jump in and talk to you.
I'm so happy I can actually be here. So first, I wanted to say thank you to Amy and everyone who has a part of bringing these consistently on Tuesday. It is so needed. It's necessary. Amy, thank you for your dedication. Seriously, I am biased. She's a friend, but still, thank you. And Dr. Hamblin, oh my gosh. First of all, thank you for the work. Your presentation was spectacular. Thank you for the work that none of us know, but actually know that you put in here, and the hours that you have spent studying and dealing with the overt and covert racism that is connected to these practices. It's an honor to be here and learning from you. I wanted to say thank you for the references because I got you, Deborah Cox. I got them all. I'm like, yes, get it done. Get it done. And I also wanted to say thank you for the work. I have a friend who at the end of last year moved from Massachusetts to California because the options of being a doula were very few and far between. So she was in various practices, and you know, as community is, and especially, you know, within BIPOC, we tend to at times take care of our own. So I was helping her raise her son, and she was going into all these different practices. And some things that you said, notice some things, not just one, was that the doula practices are about cultivating relationships. And I think many people don't understand that. It's not just a one and done. Okay, this person's pregnant and they're delivering. It's up to and even and then after in some cases. But a lot of these systems weren't paying her. So it's like she's cultivating these relationships, but how does she work and how does she pay her own bills while she's cultivating these relationships? So she had to actually go to California because that's where the job was. That's where she could get work and all the things. And, you know, the other side of that is, yes, I lost a friend geographically, but her son has lost support. She's lost support, you know, so it's just like one of those things that sucks. But I wish that we knew that you existed, this existed, because that could have been helpful, but it can be helpful for many others. So I just wanted to share that
Absolutely.
snapshot, and thank you.
Thank you. I appreciate you. And you know what? Tell your friend, like at the end of the day, there's a lot of opportunity in this space, but I think that entrepreneurship is another big piece. Is anyone on here from MAWOC, Massachusetts Women of Color Coalition? You know, there's so much work that's needed in this space, and it's great. Like, oh, this person's gonna volunteer or something. Like, I don't volunteer to do my job. I don't. Like, if you want to get me out of my warm bed, up from under my husband and my kids, like, I gotta be paid for my work. We don't ask anyone to do that other than when they are helping people. And particularly we ask Black and brown people to do it. It's ridiculous. Anybody, come on off and mute and
Thank you
talk.
so much. And my last point was I thank you for bringing red line practices. This is especially important to me because I'm having many conversations, and there are a couple of people on here I see we're very conversational enthusiasts about a lot of ingrained colonized practices. And the more conversations I'm having, I'm understanding that there's such an identity issue. It's not that this is an issue. People are like, well, you're saying that I am the issue. And I'm like, well, you're the issue if you're buying into colonized practice. Let's deconstruct that. And redlining is a very important aspect of that. And so many people, they think they know history, but they don't really know history. And it's like, well, you're saying that redlining doesn't happen now? Are we
It was never
serious?
fixed. It was never fixed. So
It
if
was
you
never
listen
fixed.
to Nicole Hannah-Jones or you read the
Yep.
1619 Project, you're going to
Yep.
see two areas where there is integration has not happened and it's not ever going to in our lifetime unless something drastically changes: housing and education.
Boom.
Look around, you know, housing and education. And so another gem, Revisionist History podcast by Malcolm Gladwell.
Yes.
Is it Miss Buchanan? It's basically talking about how the integration of schools led to the decimation of the Black teacher workforce. So even when we talk about vision of a learner, right, with Worcester Public Schools, if we don't have a workforce development plan, that is, how do we get Black teachers in the classroom,
Yep.
then we are not talking about anything that's going to result in actual results for Black learners. It's not to say that white teachers can't teach Black learners, but look at this. Who from 3 years old, you can see differences in referral for gifted programs and in disciplinary programs.
Yep.
When you have concordance with the teacher and the student, you are more likely to refer them positively. Okay. And so if that is the case, it's like, well, oh, we need to teach people to check their bias. No, we need to bring in Black teachers, bring in teachers that are representative of the community that they're teaching, that they're serving, because their absence is a result of racism.
Thank you again. I'm from the Bronx too, and I put in the chat Henrietta Lacks, just if anybody's ever interested. I know you already know the things. It's very interesting. It's a name that is still affecting us in our society, and it's sad and all the things, but it's important to know. Thank you again.
Absolutely. Thank you so much. So Henrietta Lacks, in January is Cervical Cancer Awareness Month. And so that is it's a movie, it's a book, it's history that's pertinent, like when you're thinking about pap smears and your cervical cancer screening, but again, that trust, right? Other questions, comments, and I see like a lot of my team members, I'm just wondering if people don't have questions, can like my team, both from the Collaborative in Health Equity and from the doula program, can like introduce themselves, call themselves out.
I see a question from Phoebe. Hi, everyone. Dominica here. Gonna shoot it to Phoebe first, though.
Hi, I'm Phoebe. I'm from the Worcester County Youth Action Board, and just like something you said about education really reminded me, like I'm a Clark alum from Clark University, and just the way that their like teaching grad program worked, like really perpetuated a lot of the things that you were talking about like segregation and who is given the opportunities to even like teach in the first place. Like they're like Clark is a very like majority white liberal arts college, and like their teaching program is so like there's so many barriers if you aren't rich and white. Like they don't allow you to have a second job, like, or any job while you're in the program. So in order to even participate in the program, you need to have someone funding you through the way. You need to have your parents paying your bills. You can't like have a second job because you're taking classes and also teaching full time. So just the way that they structure it really prevents anyone who is not from a high income, not even middle class, but high income background. And the vast majority of people that are in that program are rich and white and from out of the city. So I just like see that in like it's just like an example of what you were talking about. And I think I was wondering, like I heard you talk at the beginning about like the program at UMass with getting more like Black woman doulas into that program. Could you talk a little bit more about that, and then if you can connect that to education and how we could see like more inclusive programs or like programs that encourage Black people in and like other like inequities to be like addressed a lot better than just like the kind of program that like Clark has, for example.
Yeah, absolutely. So let's start with your area of interest. And I believe firmly that, one, I do not have all the answers. I have many, many questions, but I think that this collective could come up with some things. So if we're looking at it and we're saying, hey, Clark has a teacher education program. We have Worcester. Somebody pull up the demographics of Worcester public schools. I went to something and there's like 60 languages that are spoken, but somebody just pull up the demographics, please, and just give some percentages. So if we have, a majority minority school district, but if we just say like top 3 racial or ethnic groups, and then we think about the teacher workforce, if we're trying to match it up, right? If we're saying, hey, we are missing these teachers from these people groups, then what are some things that we could do as a society or as places who teach teachers? Because you have the school that actually recruits the teachers and pays them, right? Hires them and all that. And then you have the education institutions that like teach and train the teachers. And then you have the assistantship, or what is it called? The teacher practicum, something like that. Like,
Practicum?
yeah, like when you have to be in the student teacher role, right? So there's 3 places off the top of my head that I can think of. What could we do in each of those 3 places to result in a teacher workforce that reflects the community? Please come off of mute. Anybody?
So I give this a lot of thought. I have a partner who works in the public school system, and it is really interesting how he's the only Black person in a majority Black and brown student population. So, and not in Worcester, but either way, I think one of the ways is by establishing like entry to jobs that don't require that bachelor's degree, and then supporting people to get those, like if they want to advance to become teachers, for example, they can start as paraprofessionals, they can start as teaching assistants and or classroom assistants, whatever they call them, and just start with what you have, like use your resources accordingly. Like youth can be leaders in several ways. How come can they not actually get credits, like college credits, by teaching the younger ones, like assisting in a classroom and developing that interest that they already show sometimes, but they just want to be able to do something with it, and there's just nothing out there for them.
I love it. Now, am I saying your name right? Sadie?
Society, yes.
Saidi. So in the chat, thank you, Katie. We have Worcester Public Schools, 45.8% Hispanic or Latinx. So followed by white, followed by African American, 16.7. If we were to just say, we gotta get Hispanic Latinx teachers and we have to get Black teachers, and we could even say it from a 2-to-1 ratio, right? We're not talking about quotas, but this is the finish line of where we're trying to recruit, or what we need to develop. You mentioned having training programs, right? So if we're saying like, hey, when you're in the classroom as a paraprofessional, how do we get people from that to being classroom teachers? So if what we're missing, we are missing people from these people groups, it would make sense to, there are programs that exist that help people go from paraprofessional up, but maybe instead of, again, being non-specific, non-intentional, yes, we need paraprofessionals to go on, but maybe we need paraprofessionals who are in the target group that we're trying to get there. Now, how do we do this legally? Even if we think about languages, if our program is saying paraprofessionals who are multilingual, those are people that we want a scholarship for the teacher education programs. If we're saying paraprofessionals who live in the city of Worcester, those are people that we want to advantage. You understand? So I think that a lot of times we're afraid. It's like, oh my goodness, however would we find Black people who want to become teachers? Open your eyes, as my mother-in-law would say. So for those not indoctrinated into West Indian culture, open your eyes, right? Like if you're looking, you have to know what you're looking for, right? And so if you know what you're looking for, if you're saying, hey, who's missing? Who don't I have? So that was one great suggestion. Anybody else have another suggestion about how do we get to that teacher workforce that we're looking for?
Katie had her hand up and doing it with mental health and human services people. She can talk about that.
Yeah, thank you, Amy, and thank you, Cherise. Sorry, I'm off camera today, but through my grad work, I'm doing a lot of research into workforce development, specifically for Gen Z, because I help run a program at UMass Chan called Dynamic Futures for youth, specifically from underrepresented backgrounds that are interested in behavioral health careers. And so that knowledge, and then with the research that I'm doing right now, I found a couple standout things that we're pretty much already saying. One, the biggest barrier is financial for Gen Z to come into the public sector workforce, right? And then the other is cultural concordance that we've talked about a lot, right? So if I'm taking this pay cut, if I'm taking this hit, and I'm going to go into the municipalities to try to maybe do some public policy work or things like that, I'm walking into a space that is actively working against me, right? So you're not only taking the financial hit, you're taking that social emotional security hit as well, with structural racism that's baked into all of public anything, right? And then the final thing is the steps forward need to be clear, right? So if scholars are looking to go into the public sector, there's actually a lot of opportunity to grow quickly into like leadership roles in that sphere because people aren't going into the workforce, the public sector workforce as much. So I think that's a pocket of that hasn't really been tapped into too much. But I think Gen Z is looking for really specific pathway programs, right? And I know Cherise and Domenica and we talk about this a lot, right? But I think they're looking for specific pathways, right? Like in my head, I picture you're trying to walk across a pond, right? Gen Z is looking for security, right? Because they grew up with the housing crisis in 2008, and they're focused on security for themselves first. That's what the data shows, right? And also with the recent polls that came out with the election, Gen Z is turning more conservative than people thought. And I think that kind of goes hand in hand with trying to make sure they're good first individually, right? They want to be financially secure themselves. While they believe in the work of the public sector, they want to make sure they're financially sound first, is what the data looks like. So I think if we can do a better job into securing the rocks that we do have, right? Like if there is an easier pathway to leadership in the municipalities or in the public sector, because we don't have a lot of money, right, to work with to get that financial component. I think if we secure the rocks so that it's a clear pathway that they can step onto and go further quicker, I think that's an avenue that hasn't fully been fleshed out yet. But I think at the end of the day, it always comes down to money too. So being advocates and trying to get more funding into the public sector. But that was a lot. But thank you, Dr. Hamblin, for this. This is great.
Yeah, thank you, Katie. I want to pull on some of what you said. All right, look, we're saying we need young people into this. We also need old people, but we need the path to be very clear. So in this same example about Worcester Public Schools and the teacher workforce, we know what the teacher requirements are. Have we said, how do we, like if we're looking for something, you campaign for it. You put advertisement out there that's like, we need teachers. This, like we have too many teachers. Are we in a teacher shortage? I don't know. We also anybody that's going to get a job has to live somewhere. So guess what? We have a housing crisis, yes, but when we're thinking about our like needs as a community, maybe there's some developer that works within the public schools and says, look, this building here, we're going to put up your teachers in the 1-bedroom apartments and they're going to pay below market rate because the school is going to subsidize it or something like that. So you now make an attractive housing place to land. You then are actually advertising saying, who knows about Worcester and how diverse it is? I didn't know, but I also didn't know that about Lancaster. And so when you now talk about, there are places, people in New York City who are getting beat up by by the Board of Ed there, and you're telling me we can't find Haitian teachers to come and teach in this school district here, and you show them, look, hey, there's Polar Park, we have this, we have that, and you don't have the, coming from New York, where you have a super high cost of living, teachers are getting paid what teachers get paid and they cannot live, it is a better proposition. So to think about how do we market these roles to people who are coming from high cost of living places. You could even be sucking people out of Boston. Even though Worcester is really tough housing market, it's worse there. It's worse in New York. It's worse in California. You have the New Teacher Project. You have the Teach for America, which I have a love-hate relationship with. My husband is an educator, did Teach for America. My sister-in-law is a principal in New York City. So like, these are things, but just the point again, the education landscape, the same thing when you're talking about police and firefighting. Like if we want to build the community, so we might have to incentivize. One is identifying what are we trying to do? Who are we trying to get? And then how do we actually attract those people? How do we actually build a setting for that workforce to be recruited, to be retained, that is going to work? This is not rocket science. Like I'm not the smartest person in the room. I just like use common sense. And I think that if we apply that, and also honesty, like I just don't have the energy for like telling stories, you know? My mother always said, like, you can't tell stories and then you don't have to remember the truth, you know? So if we're honest about what it is that we're trying to accomplish, if we are intellectually honest about how did we get here, then we can do more meaningful work together, more impactful work with limited resources, because some of it is just about creativity. You have never met a more creative person than a person who's been broke their whole life. So every employer should be looking for people who've experienced poverty, people who've experienced some kind of hardship. They are the people who are not going to complain. They are not going to be the ones telling you like, oh, I had to stay late. They're like, listen, I am so happy to be here. And we see it in medical education as well. And so we just have to be thinking, be thoughtful about it. I could go on and on for days, so please don't, you know, don't let me just rant.
I can't remember who it was, but somebody had their hand up wanting to share. Please jump in. It's really valuable to just have this conversation and hear what other people are thinking. And I really appreciate that we sort of branched into education as well, because I'm a social worker. You see the same problems across the board of really white workforces, and lots of systemic barriers.
Yeah.
So
And I
I wanted
know, oh, go ahead.
Just I also could talk about this all day, so I try to mind my time. I work in healthcare as well, community health center, based, and it's really discouraging how even where we are, even where I work, that quote unquote understands that they are vulnerable populations that we are trying to care for, trying to cater to, but we don't have leadership that looks like us. We don't have people who are making decisions based on lived experience, only on bureaucracy, and you just I think someone mentioned leadership paths, and it's really it's like not even an uphill battle, but I think that you have seen that that caricature of what a Black woman has to go through to get to the goal versus what a white man would, and then it feels like that and then some if you want to try to get into any position that can support others better, any leadership position of the sort, across the board, and especially if it's local. So I think this is more a comment than a question. It's really how do we support people like myself? I'm definitely speaking for myself here, who are trying to get to a point that we want to do better. We want to provide better service. We want to be able to get creative in the ways we do it because the resources are there. It's just how we use them and then the willingness to kind of just like rock the boat, not always just be complacent with how things are done. Any suggestions, any feedback on that would be nice to have.
I love your comment. Where I came from, you know, it's like, okay, FQHC, I love FQHCs. And they would look and you're like, wow, the MA workforce, the nurse practitioners, the mid-levels, all of that. And then you go to the doctors and they just had, you know, white doctors who were bilingual. And I'm like, and the board of directors. And so I think that leadership, right? All of us represent different areas. And I think that, you know, some will say like, oh, you know, we're preaching to the choir, but are we really though? Because have we looked at our own organizations? Have we looked at our own structures to say, hey, where is the representation in our leadership? And then sometimes we're not empowered, right? Because like, okay, you're going to bring it up, but then what? So I like to say, starting with working within your sphere of influence, right? And so each of us has complete influence over ourselves. And so what you can do is saying, number one, what boards am I on? Because there's a board out there that either your kid is participating in some activity or your child's school or something that you're doing that board needs you. And so think about that. Like one, it's like, what boards am I on? And if you're not participating, particularly if you are a person of color, like think about it. What makes you move or what are you interested in? And then get on a board that is a well-functioning board, not something where you're going to work yourself into exhaustion, whether yourself, like Arlene Geronimo said, until an early grave, right? But think about, listen, if you like the Hanover Theater and you go all the time, go look at the board, send an email. You know what? I love the Hanover Theater. And I see that you said this thing, and I'm really interested in being on your board. What is the commitment? Can we go to lunch or something like that? This is what they do. Some people, they spend all their time. When I thank you for the follow-up question about a functioning board, every single nonprofit has to list their 990. They have to. Somebody put a nonprofit out there. Like, just call something out. Somebody, just say it out loud.
I see WCAC in the chat.
All right, WCA, what does that stand for? Worcester
Community Action Council.
Somebody put in there. Okay, Worcester Community Action Council 990. Worcester Community Action Council, first hit, ProPublica, Cause IQ also. Look at this. So when people, you see, I'm about to get uninvited from this gathering. Every time I hear about a nonprofit, I do this. I look it up because I want to see. And this is all public record. That's what you get when you're a nonprofit. Okay, so Worcester Community Action Council, tax exempt since 1965. Here's the EIN. Look at the revenue. Look at the total assets. You can pull the whole audit. And this is salaries, and then none of this is private information, executive compensation. So when an organization comes and tells me like, or says, we just don't have any resources, right? This is different. This $43 million in revenue last year, they filed their 990s on time to have their 2023 data out here like that. You know, you got money. Give me another one. Somebody else. So remember that $43 million. Here we go. So an organization with $43 million is going to have a board and have a and have staff, right? When I look this up, I don't think this is going to be it. So somebody give me another one, another organization.
Even the NAACP has a lot of white leadership.
Okay, but I'm talking about just their money. So
Yeah, I
we're talking
would,
about a functioning board, right? If you have, so you have your board, boards are not paid. They are the governing, they're the governance, the guiding people that look at the, they look at the, like the bylaws, and they look at the strategic plan of an organization and say, are we working toward our goals? How are we doing? What do our organizational documents say we should be doing? And boards may meet once a month, they may meet once a quarter, right? And the boards are not paid. And then you have staff. So if we just look at, tell me a small organization in
Southeast
Worcester.
Asian Coalition.
Southeast
One of them.
Asian Coalition of Central Massachusetts, and then we'll go like this, 990. Here we go. So $43 million, 1.7 million. This is still not broke. Okay, and tax exempt since 2000. When you go, oh, see over here, you do this, view filing. Like I said, I'm gonna get uninvited. But literally, okay, so even if you're raising money, you could look at anybody, if you give somebody or whoever you receive more than $5,000 from, it has to be listed. So you could literally scroll 990s, figure out who's giving out big checks, and then write to them and ask them to support your organization. But you should, if you're working in this, and so you again have board of directors, and this is saying like 1 hour a week, and then you have an executive director, 40 hours a week, and you have a salary. This is public record. So even the hospitals have this. Now theirs becomes like 100 pages, and it can be very kind of convoluted. So it's like harder to understand, but it's all the same information. These are the same forms, and it's year by year by year. So sometimes we're looking at, nonprofit organizations, and we're thinking that like every nonprofit doesn't make money. The NFL is a nonprofit, right? But when I think about a functioning board, it's what is my time commitment? What type of decisions will I be making? And then internally, I think about what am I going to gain from being on this board? It has to be something I'm interested in. So, a couple years ago, I wasn't on any boards at all. And then I was like being asked to be on all kinds of things. I'm not going to be on a board where all we're doing is trying to raise money to keep the lights on. No. I didn't even, I grew up in the Bronx. My lights were always on. I did not experience poverty as a child. I am not going to experience it as an adult volunteering on a board. It's not my jam, right? And so you have to think about protecting your peace and what space you want to be in, right? But there's a lot of nonprofits that really are not functioning well, and they may be doing great work. But if you are starting within your sphere of influence and saying, what can I do? What is going to be my contribution? If you want to be working, you have a job. I don't know that I've ever met anybody who's like, you know what, they just pay me too much. Right? So if you're already like working and you feel tapped out, like why would you join something that's going to have you working more? But you can gain something from being on a board, and you can offer your perspective and your influence to the things that that board is doing. So for example, at the Hanover Theater, you might be like, oh, I'm going to have influence over who we invite as the, because I want to be part of the arts and culture scene here in Worcester. I love music and theater, and I want my kids to be able to go to things that are reflective of them as individuals, and it's not just like we're the only Black people in the room. You may have something where it's like the Education Foundation, and you say, look, I'm not a teacher, I'm not training teachers, I'm not recruiting teachers, but you know what I can do? I can be a part of how we support the teachers who are teaching our kids. And the Education Foundation, whether it's raising money or whether it is, and every education foundation works differently. Some are like, hey, we have this endowment, and we have this working capital, and this is what we do. We give grants to teachers in classrooms, et cetera, et cetera. So there's lots of organizations that are doing great work in this local Worcester community. You can always look up any nonprofit, find out what they have, who's on it, and like think about what you want to do and do that. And then for the outside of you, it's like, okay, you have yourself, you have your family and your community. And then you have like more broadly, if you're a part of a system or a structure, like what is the commitment that that system has made about the leadership and reflecting the community? And there may be somebody on this call who could be on the board at your organization that you can make an introduction, right? Like you work somewhere, you're not going to be on the board too. So it's some of it is this inside outside work. You can be in a system and you also have to work outside of a system. That's how we can get things done when you think about weaving together the kind of a network of change agents in order to really impact our local community to see something different than where we've been, because where we've been is really trash. Not specific to Worcester, I mean like society in general. There's Leadership Worcester. I mean, if you look at some boards, I mean, listen, I got a whole MBA off of YouTube. I mean, I don't have an MBA. I've gone on YouTube and learned how to start a nonprofit, how to find the 990s, like the information superhighway. Listen, this stuff is out here. You don't need something like, you're all smart and professional people, and we all have good minds and can learn. Go on YouTube. Find a channel you like, nonprofit for dummies, you know, what does it look like for a board? How does the budget? Pull up the budget of the institution or the organization that you work at and look to see, so you can understand how to read those 990s or look at, you know, grants and see. It's just the information is there. And I think that we can do a lot more than operate in frustration. It doesn't help us and it doesn't help our work if we are frustrated. So it's like, what can we do?
Hello, my name is Angela Keith. I just wanted to say thank you for this. I am not in any type of way in the medical field. I actually stumbled across this by chance on my Facebook group. I'm a born and raised Worcester native. The reason why I wanted to join this today is because I had lost a pregnancy in July and I had lost a pregnancy in November. Not with your company, I'm gonna say with your competitor in Worcester. I faced a lot of those racial issues as a patient there and did not know what avenues to take to just, you know, get the proper care that I needed as well. I am a life insurance agent, and the reason why I'm in this business is to educate our communities on how to reach financial security through life insurance, as well as cover your if you're gonna get sick, fertility and other issues as well. So I just want to say thank you so much for this, because it's very informative. Just putting the information out there to the communities and making it accessible to people is very helpful. So thank you.
Thank you so much, Angela. And I'm sorry for your loss. I will say that if, you know, I think that our stories, our own experiences, months can go by, but you will remember it and you know the details. And in the moment, it may feel like, who am I going to complain to about this, or who am I going to bring this up to that's going to do anything? No one's going to make it better. But when there is no paper trail and there are bad actors, unchecked people continue to go unchecked. So if you have something that, you know, you feel like, you know what? No, this was egregious and somebody needs to know about it. If you have resources about, you know, how to report discrimination. So in an institution, you can report a safety concern. You can report a patient care, like there's like patient advocacy. But then also, I want to say that Worcester has a human relations commission or something. If somebody has the right terminology for like how to report discrimination in Worcester, I think that sometimes we really, those of us who can shoulder those burdens of taking the time, writing the letter, calling the people out, or calling out the specifics of the circumstances, because it's not just like, I mean, I'll write a letter to Delta Airlines if they lose my bag. You better believe that as things get more important than my bag, one of the strongest tools that I will have is always going to be the pen. But it's also draining and it's emotionally draining. I have a situation right now that I have not complained about in writing, because every time it's just draining. And so if you speaking kind of to the collective, if you feel like, you know what, there's something, but I can't engage in this further, because it's not like I could just say it and then it's over and done. It's going to reel me back in and I have to relive and all of this stuff. But if you do have it in you, when you experience something, to call it out in writing one time, not a back and forth email, because guess what? There's nobody that you're going to email who is going to then take it to like, this goes beyond that person. Reporting things so that there's a record is not an email. It's like, it's a letter. It may be sent by email, but it's sent to multiple people. There may be a reporting structure in your institution, but it's definitely like, take that time, write it all out, say the names, and put people on Front Street.
I appreciate that. And I appreciate you sharing that, Angela. I think personally, I know women of color that have had really bad birth outcomes in Worcester. And it is really hits at a whole different level when you're just seeing numbers on a page, and when people you care about have had these experiences in this state that's supposed to, that prides itself on being more equitable and out front with education and health. And yeah, only for some people though. And that's why it's so important to look at this. And I always think about the connections between birth outcomes and birth experiences and what those children are going to go. Like, we now know that your brain is forming before you're even born. The experiences your mother is having are setting the stage for early childhood and for the rest of your life. So the work that you're doing, this is like changing generational outcomes. This is not this one moment on the stage of life. This is improving outcomes for women of color is going to improve our population. It's incredibly important work. And I don't think it's lost on anyone here how needed it is. And I'm sure I've said it every year of my life, like, we need this more now than ever, but like, we really need this kind of information and this call to action more than any time in my adult life I can remember. It really feels like the culture is saying we only care about this one group of people, and most of us aren't in the groups that they care about.
Thank you. That's super powerful. I don't think we got to everybody from the teams to introduce themselves. I know that Sammy and Dominica, thank you guys for coming. And I just saw Chantel. I wanted to give you some airtime, please. Can we, yeah, there you go.
Hi, everyone. My name's Chantel. I'm the Doula Program Coordinator at UMass Memorial Health. And I also want to introduce to you Renika and Glade. She's our complement to our team. And together we work with Dr. Cherise Hamblin. Thank you so much for inviting me to this space and to participate in the chat. And I hope you can click on some of the links that we've posted. Quite a bit of content, so put it in your favorites and check it out later. And for those who put their email in the chat, I'll be following up with more material for the Doula program. And I'm gonna see if I can get Dr. Hamblin's grand round session with Nakia Lawson viewable to you all through email as well.
Thank you so much. I loved all your chat help. And Worcester Addresses Childhood Trauma, we record all the sessions as well, and we'll try to put all of the resources you have here also on that landing. We have a landing page for each session that is supposed to have, more resources, more places to go for information. So anything you have for us, we'll locate that there as well, and, support you in getting the word out about this great program that you guys have.
Thank you so much. I want to, we'll share the links, but if we were closing up, I want to show this video because I just got it last night and I'm like, oh my gosh, look at this video. Are you seeing my screen?
Yes, we are.
Okay. Are you hearing?
Not
No.
hearing it.
Is a
Not hearing.
non-medical professional who provides some educational,
Now we are.
emotional, physical support for individuals when they're getting ready to have a baby. And so really doulas kind of guide and navigate the birth experience. And so our role is to kind of help facilitate an experience. Hopefully that families realize that they can have a safe, satisfied, empowered, and dignified birth experience.
Being a doula means to me, it means advocacy. It means being there for your clients. It means supporting them in the most extreme time in their lives.
I had a doula for my birth, my first birth. To this day, I call it a unicorn birth because I should have been a statistic. And I know I wasn't in part because I had a doula. I'm a doula because I love Worcester. Worcester's my home. This is where I live. This is where I eat. This is where I play. This is where I worship. And if my neighbor is healthy and happy, I am healthy and happy.
In my own life and people that I know, in my family and my friends, sometimes it comes down to not having enough information and not having people advocate on your behalf or help you feel empowered enough to advocate for yourself. So I see being a doula as an opportunity to provide people with information so that they can make informed choices and be able to amplify their voice in a way.
My favorite part of the doula training so far has been the medical minute. In addition to our weekly doula trainings, we have an opportunity to meet with Dr. Cherie Livingston and Dr. Cherise Hamblin and ask them all of our questions about anything that we might have learned. Being able to have access to board certified OBGYNs to ask them any question that I have as it relates to my business and my new practice has been invaluable to me.
So I always wanted to be my own boss, have my own schedule, and do my own thing, like build a business. So this was like a perfect opportunity. So when we came to the information session, it was like a light bulb. It's like, okay, this crossed all the boxes.
Dr. Cherise Hamblin, founder of Patients Are Waiting. We're so excited to bring the Diversifying Doulas initiative to the Commonwealth of Massachusetts. This is our first time doing doula training outside of Pennsylvania, where DDI started. And I can't wait to see what our DDI trained doulas will do to move maternal health in the way that it should be.
Oh, thank you. Like, commercial.
We'll link that for sure.
Oh my word. Well, there's so much that was really shared here. Thank you so much. I'm still fine for time. So if there's other things and folks want to talk about, Kelsey.
Yeah, this bubbling up piece around safety, right? You want to, folks that are getting ready to give birth, you want to feel safe. You want to feel safe in when you need support, when you need care. And Amy and I have gone back and forth many times about, okay, if our hospitals aren't the safe place to give birth, like what is this? What are these options? And her and I talk about this probably on a monthly basis, right? Like at least once a month. We're great, but how do we hold our medical systems accountable for a better standard and a better outcome and all of this? And I feel like we haven't just directly talked like from a safety lens, right? As an individual person trying to access care, we're looking at these big systems things, and the systems in the history really shows us, yeah, well, the systems aren't safe. They weren't designed. They were coming out of these terrible systems of racism, of colonization, of all of these things that are so harmful. And just knowing the doula program is available and it's a resource, it starts to shift that perception of safety in our medical systems. So thank you.
Thank you, Kelsey. I want to poly with you, right? So when I think about safety, right? There was a little guy in the video, he's about to turn 6 and my daughter's 8. And, when I think about like, where do I feel safe? I feel safe When I walk into a space and I see a lot of Black people, I feel safe. When I walk into a space and I'm the only Black person, I still feel safe for the most part, right? There's certain things that make me feel unsafe. I don't feel safe when I see police. I don't feel safe when I see someone with a gun. I was in Vermont this weekend. We're driving by. There's a guy on the side of the road with a rifle, full camo, like he's clearly hunting. But I'm like, I didn't feel safe, you know? I don't feel safe hiking. There's a lot of things where I don't feel safe. If I'm pregnant, I have to decide where I'm going to deliver this child. If my home is where I feel the most safe, and when I look at the risks and whatever, and I say I need a home birth, then I'm going to now align my resources, whatever those are, to having a home birth. If a birthing center is where I feel most safe, I will align my resources to do that. Now, if I don't have additional resources outside of my insurance, then I'm disincentivized to give birth at home or in a birth center. So my option, 96, 98% of births are happening in the hospital. So the idea that like, oh, we have so much choice. We don't have choice. People are going into places they don't feel safe all the time. People are going to school and don't feel safe. So not being safe is not a new thing for Black people. It's not a new thing for people who are not centered in society. So then you're always calculating risk. And you're like, all right, what's my risk assessment of this right here? All right, so I'm going to find the doctor or the care provider that I feel most safe with, where I feel the best. I'm going to choose from the best of my options because that is my experience every single day, every single context. So sometimes, you know, we can like be, you know, in community and we're like, we're trying to do this great work and we all care so deeply and all this stuff and this is great. We're like, everything's wrong. We throw up our arms and guess what? I'm still Black. So I have to navigate this world in whether it feels good or it doesn't. And I'm constantly in a risk assessment situation. And like for good or bad, like I know sometimes our places of work will be like, well, we want to recruit, but we need to be ready. It's like, stop. That to me is kicking the can down the road because if you ain't ready today, you're not going to ever get ready. Right? So if we it's a convenient narrative to be like, well, we have to ready the place, but ultimately people are experiencing care right now and they are risk assessing right now. And so the person who does not speak English has huge barriers. The reason why they're on their phone is so somebody else is able to hear what's going on, right? Like there's a lot of things that people do to manage their risks. And for all of us who are in social services, we have to recognize that. We're not going to fix everything in one day. We're not going to fix everything in 1 year. We may not fix everything in one lifetime. So I think it's very important to understand that some of us can be like, I put this lens, and if I look through with this lens, I got one lens. I got one pair of eyes, right? And I have one set of skin. And so I show up as me all the time, whether I'm trying to or not. And understanding that, I think, is really important because it helps us to know, hey, maybe the role that I can play, maybe the best thing that I can do is help this person either assess their risk or be sure that I am a safe space, right?
Thank you. I was nodding along the whole time. Just, yeah, just that reminder, the risk management is baseline, right? That's how I took that, right? Always, every situation, always recognizing the risks, the safety, and making the best decisions within our resources and all of that. Everyone's doing it, right? But we know that the risks for Black folks are different, right? Because of racism, because of the society that we live in, right? And the piece about being a safe person, that's the nice reminder, right? Back to the sphere of influence, that's in my control, how I respond. I know in like the narratives that I hear around birth are not positive, right? they're traumatic. They're moms and grandmothers and aunts sharing these terrible experiences, these awful experiences that they had over their lifetimes birthing, and hearing stories, and they're passed down generationally. And so the work, just in the conversations I mentioned that Amy and I are having, are starting to tear apart some of that. We don't want the next generation of our, in my case, it's my peers that are birthing people right now, and they're really, and I'm saying, wait, but I heard that, and I had this misconception, but it doesn't serve the person giving birth. It doesn't serve the new family. It does, those beliefs maybe don't serve us anymore. And they're historical. They're being passed down because the trauma of giving birth has been passed down in so many ways, in so many generations. And so just, I think personally getting ready to start a family and all of that, really, I've been really digging into, how do I want this to feel? What feels safe? What's the vibe I want around me? What's the mindset and all of that? And so it's really just really great to hear the different layers, historically, current, present day programming, and back to that reminder of what's in my sphere of influence. Thank you.
Thank you.
Anyone else want to jump in? I do love what you started with, Dr. Hamblin, of the birthing person should be at the center of the picture, not the physicians, not the hospital, the birthing person. And even just starting with that really sends a whole different message and sets is a very different experience when the patient is actually at the center. That would look really different than things are now. And the fact that that's where you're starting from feels like the exact right thing to be doing. And you know, obviously everyone here has expressed how grateful they are for your work, for your honesty, for your willingness to be in that space of the hospital that can be really challenging, and still being able to be yourself and honest and talk about, I'm impressed. Really impressed. Let's hope you end up staying in Worcester and you don't like get the whole like, okay, this is not what I thought it was going to be, and leave in a year. We're going to try really hard to make sure that this is a place you want to be. And I love that you have a great team of people with you that are going to make it so much more likely that you stay here, because you know we've got Worcester people on that team, and the best people.
Thank you so much. You know, we need some housing stuff here. And the amount of people I talk to in the hospital who all live somewhere else, I'm like, home in the city program, where the lenders at? Let's go.
Yeah. Yup. Exactly. And Angela had asked about more trainings. Our next month training is your colleague, Dr. Johnson Akwahu. Did I say that right?
Akwahu. Mm-hmm.
She's coming next month. So that is going to be equally enlightening and amazing. I've seen her speak a bunch of times, and every time I learn more things, and I'm so impressed. So more to come. If this is a topic that people are interested in, we will make sure you get the scoop on our next one. And feel free, Dominica, if you want to jump in and say anything about that, or anybody else from the team.
Yes, Dr. Johnson Akbaku is brilliant, has a wealth of knowledge, definitely can complement this presentation, and her area of expertise is actually around female genital mutilation and cutting, which is actually what the topic of her presentation will be about, and the stigma surrounding people who have undergone that practice, and how that intersects with all of our systems. So I think that will be a very interesting topic, and more on that soon.
Thank you. Thanks so much. All right, should we call it a day then?
Yeah, thank you so much for everyone's time and attention, and for your, you know, interactiveness. Really appreciate everybody's contributions to the session and for going with me a little bit when I go on all my little rants and whatnot.
How fun
Wonderful.
was that to see the connections overall, the rants, the tangents, whatever they are there. It was beautiful. Thank you for bringing us there.
Thank you so much.
Thanks, everyone. See you next month.
Take care.
Thank you,
Bye.
everybody.